And it's past. I'm going to. Good evening and welcome to this meeting of the Adult Social Care and House Select Committee. I am Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. The event is being streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to discussions taking place. Now I welcome all of those to Committee Room 1 at Kensington Town Hall and everyone watching on YouTube. Before we proceed with the meeting, I would ask everyone present to make sure that your mobiles are on silent or switched on. And we will start with 2 seconds silence to remember those who lost their lives in a Grenfell tragedy. Moving to agenda item 1, apologies for absence. Cleo Chalk from Health Watch has submitted her apologies for lateness. And I know Gerald wants to Hargreaves needs to leave very early. I believe Roberto and Mona might also be a bit late at the moment. Agenda item 2, declarations of interest. Does any member have an interest to declare? And then minutes from the meeting held on the 19th of September. The minutes of the previous meeting have been circulated. Does the committee agree that they are signed as a correct record? Great. Happy with minutes?
I have a question that was listed. So it was a bit in the
minutes.
If you clarify the point, I can add it to make it recorded in this meeting.
Okay, thank you.
Okay. And moving on to agenda item 4, which is the Safeguarding Adults Executive Board Annual Report 2023 to 2024. This is the annual report of the Safeguarding Adults Executive Board, which produced in accordance with the statutory duty to publish yearly. A report which includes the business plan for the year and any safeguarding adult reviews. Eileen Buckton serves as the chair of the board, and I'm pleased to welcome her here tonight to present the report. Before we hear from our guest tonight, I'd like to express on behalf of the committee our thanks to Professor Jill Nanthorpe, the Policy Institute at King's College London, for independent expertise on adult safeguarding and input shared in advance of the meeting. So we've got attending Josh.
You're like the third chair.
Josh Randall, Louise Butler, and Eileen. Thank you.
Thank you, Chair, and thank you, Committee, for having us this evening, and to Jill as well for her contribution. We have here, as we do every year, the report from the Safeguarding Adults Executive Board. We have Aileen here, who is the independent chair of the board, who will be able to speak in much better detail to the report's contents and what we've done as a borough, and all the other members of the committee that takes a look at adult safeguarding. And as you know, we're a range of many issues, but we also involve not just the council but other external bodies such as police, fire brigade, NHS colleagues, etc., whoever needs to up there as well. So as I said, really welcome Amy this evening, who can speak about the report in detail, and I can contribute if and when needs be. But having to take questions.
Thanks. Good evening, everybody. I want to present to you tonight our 7th safeguarding annual report since annual safeguarding boards were set up for adults. It is a statutory requirement that we do produce an annual report, and it's really important for me and for colleagues working across the partnership to have this opportunity to for you to kind of scrutinise the report, to scrutinise that year of 23-24, because it's a very important line of accountability for us. It's also very apt, actually, the time of this evening, because this week is National Safeguarding Week. And across the partnership, people are doing various kind of activities, both nationally, regionally, and locally. In this report, you will read about some of the kind of activities last year in National Safeguarding Week. And I was really pleased that this partnership was asked to lead a kind of national seminar on hoarding and self-neglect. And it kind of reflects, I think, what has been a priority for us during that year to build our kind of partnerships with housing. We have very close relationships with the Directorate of Housing across both councils. And what we have been able to do during that year is to build relationships with registered social landlords. And we are seen as being a kind of leader in that work, because what we want to do is to make sure that all landlords understand about self-neglect and understand about hoarding and other kind of related safeguarding issues. And it's really important that those who are working on the kind of front line with families and single people as well actually pick up on and are thinking about some of the kind of key safeguarding issues. So we're very pleased that that work has been developed and it's gone on into this year. So I just wanted to start with a kind of comment about the National Safeguarding Week. The theme for us during that year, 23-24, was very much to kind of continue our work on community engagement. And on the front cover of the report, you will see the new network that has been set up. So it's a Black and Ethnic Minority network for safeguarding. And this work, I talked a little bit about it last year, that we were doing kind of work with various community organisations, trying to build links with people from a huge kind of range of different communities, and particularly those communities where English was not their first language, to try and facilitate some dialogue about what safeguarding was, and to make sure that people from as many communities as possible across both boroughs had an opportunity to be able to kind of raise their concerns, but to understand a little bit more about the work that we do. It was so successful that they themselves, so representatives from the community groups, representatives from the community, interpreters, all wanted to come together and form the network. So we have the Safeguarding Network, and we didn't launch it in that year. We launched it in May, but all the work was done for it, and we've had a really, really good turnout, and that work kind of continues. So we now feel that we've got a kind of outreach programme into many different communities. And our safeguarding ambassadors have also continued their community engagement work. They've been out and about. For example, they attended a session with some carers and parents of people living with somebody in the family with learning disabilities. And again, we're sort of very much putting the kind of message across about what safeguarding is, and ensuring that they're kind of building up contacts with different sorts of kind of communities and different, reflecting different needs across the borough as a whole. So they've been extremely busy, and they've been doing lots of work with the police and the fire brigade as well about getting those messages across to the communities about different forms of kind of safeguarding So we're really pleased that they've continued to be as involved as they always have been. In terms of our data for the year, what's very important to us is that the safeguarding referrals that come through reflect the kind of makeup of different kind of resident groups and communities who access adult social care and access kind of health services in terms of having social needs. And we're very pleased that that kind of the reflection is there, absolutely, so that we don't feel that there are kind of particular kind of communities who aren't making safeguarding referrals and that they aren't being met. So we're very pleased about that. And also the other thing that we have to collect data on is when we do an inquiry for safeguarding, of making sure that that particular person or family feels that their kind of outcome of what they want to see happen of the safeguarding review, that it has happened successfully, and that they feel that they've been listened to and responded to in the way that they wanted. And I'm pleased to say that the percentage of people that was the case for during that year was 98%, which is above the national average, and I think is a real kind of reflection of the changes that have been made across the partnership about how those referrals are made and making sure that people are kind of responded to appropriately. And we have continued our learning and development work. We set up during that year, we set up a task and finish group on fire safety. We've been working with the fire brigade to make sure that we've got a very comprehensive programme that we're now going to be able to kind of take forward to deliver. And lots of our kind of community representatives have been really interested in that work and involved in it. And lots of other kind of areas of specialist learning and development. We've done some work around pressure sores, for example, of making sure that our care agencies and families looking after somebody at home, making sure that they understand about pressure sores and making sure that that we raise kind of alerts as quickly as possible. So some quite specialist areas of work, and you will see there in the report other examples of our learning development. And we of course continue our main programme of safeguarding training. So I won't go through the rest of the report. What I would say is, well, it seems to get bigger every year, so you'll be pleased that I'm not going to do any more than that. But I just wanted to kind of pull out some kind of highlights for you. But obviously, we would be very happy to answer any questions.
Thank you very much. And I just wanted to start by saying it really highlights again how strong our safeguarding practices are, with a clear focus on our sort of innovative working together and constantly improving. So it's great to read. The only thing I was going to say in terms of the report, which I don't know this would have been great to have a bit more about our kind of the areas we wanted to get into, auditing and stuff like in the cover report, but I think it is featured in the report, but just noting on that one, as I think I wanted to make a flag of it. But I'm going to start by going to the committee question. Okay, thank you.
Yes, so thank you very much for that comprehensive report. I had two questions actually. One regarding self-neglect and hoarding. So it does mention the lack of data, or actually beginning of accumulation of data nationally. And so I was just wondering how you're planning to collect data, and how you're planning to measure the potential risk associated with that particular behaviour, which is something we're seeing more and more. And then my other question was the key performance indicators when you have partnership in place. So how do you measure that? And I guess I have a third question, perhaps. And how do you work with social housing? It's also something I wanted to explore. So, right, the 3 points. Sorry,
So if we kind of start with the hoarding, which I'll ask Louise to talk to you a little bit about the kind of detail about the data that we're going to be collecting, but the recognition of the risk I think we've talked about this a lot. It's about making sure that every single landlord, in the first instance, understands what self-neglect is and what the early signs of it. Because the earlier that we can start to work with people, the chances are of getting kind of better outcomes.
And those are identified behaviors. You can now trace what is a non-set, a holding, self-neglect behavior.
Yes, I mean you can obviously, it's obviously much better to try and work with staff that they work in a particular way to ask questions, because sometimes people are very ashamed and they don't, they don't want to kind of allow access necessarily into their accommodation. So you actually look for early signs about really having professional curiosity.
Okay.
Of actually getting people, whether it's a GP, somebody in, perhaps in A&E, if someone's being discharged and they realise that, actually, this isn't a suitable kind of flat for somebody to go home to. But it then raises the question, is this a kind of ongoing state of affairs, or has this just come about, very recently? It's those sorts of things, and also getting the messages out into communities, because neighbours notice. And I think it's about trying to get people to think, I wonder if that person's actually okay, because there seems to be lots of kind of rubbish, piled up outside in the garden, or whatever it is. And so I think we have to do risk assessments based on as early an intervention as we possibly can. And the best way to get that to happen is to get the message out there, to get, so that people understand it, because it is a real illness and is something that has to become tackled. And the sooner we can do that, the better in the process. So it really is about trying to get that message across at a community level.
I have experience with that myself, Chair. So we had a very good family friend of ours who is in her 80s. She used to come out frequently, but she was very nervous about people bringing her to her house, actually. And obviously, no one could visit her during COVID. And post-COVID, we managed to get there, and she was hoarding, which was really, really sad. But it was the early signs that perhaps the rest of the community hadn't spotted. And one of the early things that we found out, that part of hoarding as well, and ailing and Louise may fix this a bit further, it also sometimes can be a sign of early onset dementia, of which our family friend did have. So she's got the help and assistance now. We've moved her out, obviously, helped her deal with the mess and everything else, to ensure there's safety there too. And one of the things I took great comfort in is when I visited the Chelsea Westminster Hospital and visited our discharge team that are based there. Like Aileen was saying, when people are discharged from hospital, sometimes they can also go back to a place which is not suitable for them. And I was impressed with the team. For this particular one example, there's one lady who was going back to her home in Knightsbridge, whereby she just collected newspapers, and the newspapers were by an open fire. Obviously, that was danger to herself, danger to the wider building that she lived in. But the team and officers and hospital team really went out of their way to try and help her do this. And I think that's a really good sign of kind of our proactive nature, perhaps, that we have culturally in the borough, to try and get the help that they need to ensure not just safety for themselves, but safety for the wider community, and ensure that they can get that as well. But I think there's a bit of a stigma to it. People probably do know that they do it, and they just don't want to ask for help.
Yeah.
But it's just encouraging the culture for that help, I think, which again happened with my family friend and this lady that opens at the hospital, and they're really well now, and they're just continuing with their life the best way they can, which I think is the most positive thing we can get from this.
Just on that point quickly, in terms of how, say, for example, neighbours, community, people around someone who might need that support, how are we kind of communicating the message? And also, what is because there is that stigma, I don't know if a neighbour would feel like they were maybe not educated on hoarding, that they were kind of sneaky on someone, not knowing where to go to, that actually what they were doing is being proactive and helping that person rather than being, oh, this person's behaving in a strange way. How is that message kind of communicated? Because I feel like that must be something you face. Be interesting to hear that.
Shall I step in? This one, and listen to what to do with the things. So off the back of the last year's Safeguarding Adults, Safeguarding Adults Week, Doug Goulding, Director of Housing here, and I got together because he really wanted to be much more proactive in understanding about what's happening with hoarding. So what is the data telling us? So we are now collecting that data. So I know, for instance, there's 93 active cases sitting in housing in Doug's housing service at this moment in time, and they're all being worked on. And we have set up a plan in place whereby social services and housing are working together. So there are 39 cases in adult social care, but only 15% of those cases are being worked out together. And that is because we now know that, in fact, a large percentage of the cases, they do not have health and social care support needs. And so they're being worked on by Doug's team. So Doug has got in place now, and he's allowed me to say this, by the way, he's got in place now a whole system whereby we are having some joint training. Now, joint training is a fantastic mechanism. Not only is a little bit of a savings agenda attached to it, it also means that we are working together. We're cross-pollinating ideas, we're understanding how each different service works, and we're running an excellent training in order to get some key messages out, not only to the workers, the housing support workers, but also when it becomes more complex. So, for instance, they're getting involved in understanding about dementia, Mental Capacity Act, what it looks like within tenancy sustainment. So we're not just going to go down an environmental health, get that person out. We're actually working with them, and this does take a long time to do that. So the training is supporting the workers to understand how to work with these service users or with these tenants, but for maybe 9 months. There's also a step down process, and that step down process is whereby the clearances have been done, everything appears to be, and it just needs to be monitored and reviewed. So we have in place a sort of neighbourhood support coordinator who will pick up those cases, who will monitor and review them. In the same way, in adult social care, those cases go to the review team, and we will begin to monitor and review those cases. So we're also looking at clearance costs. And we're looking at, and we're without wanting to do a quick workshop on self-neglect and hoarding, we categorise everything using a clutter rating scale, and then we can actually manage it when we know a bit more about where that person sits, what their motivation is, what their engagement is. So all that data is collected and it's filtered, and we now have meetings every 6 weeks, like strategic operational meetings, where we begin to look at having a sustainable system in place where we're involving the registered social landlords and environmental health as well. So that's a little bit about the work we've been doing the last
One thing I would say, Chair and Committee, is that I think we're very, very good at the social housing element. When it comes to perhaps other housing, private housing, I'm not sure.
Yeah.
Which is where the challenge remains, which is where this lady that I've witnessed just was, because she was a private, she owned her flat, but
That's what I mean.
it wasn't picked up because of that way.
And that's why the community messaging is also important, and to make sure that we get those messages out, as well as working with all of the landlords and with staff. And the training programme is absolutely right, but we do need to rely on communities to respond and to tell us, because otherwise we're not in contact with those residents.
Just because I think unless I was sort of in this role, I don't think I would really understand how local communities were supporting or educating people about this, and to someone who really doesn't know what to look out for, and say they're in a private building where there's an elderly person who's hoarding, how would they know? How are we communicating them to know what they can be doing? Is kind of something. I know you're speaking to landlords and just
And caretakers.
yeah.
Because care agencies are a key.
Care agencies, and also faith groups as well. Faith kind of communities, really, of making sure that we get the messages those ways. So using our kind of ambassadors and using our networks to make sure that we get those messages out, really, as But because it isn't something, it's not something that people talk about,
Yeah.
and it's difficult to break it down because the whole stigma attached to it is
One of my pieces as well that we witness as well is that loneliness is a huge thing, especially in London, and especially for our people who perhaps are older and older generations, and that can be a real thing as well. So you could live in private accommodation, but no one would check in with you because you're a certain age and you don't really know anyone and you don't know your neighbours. I know it's very easy to say check on your neighbours, but genuinely check on your neighbours, because that is often half the battle to get to know them, to get to know some of their concerns, because they're by themselves, they don't speak to anyone days on end, then that can also exacerbate.
It's also holding, isn't it? We get with casework. It builds up over time. It's not an instant thing. It's not like someone has a fall or someone has a stroke or something. It builds up over time, and suddenly you realise it's a problem.
Yeah. And sometimes it can be it can be the kind of early signs of dementia, but very often as well it can follow a loss that the person has experienced,
So
and causing them
mechanism.
and causing become
Mm.
often after.
Do you have any more?
Yeah. Thank you for the report again. It's always, apart from taking a long time to read, it's always very, very illuminating and very helpful. And the pictures make it easier. So thank you. A couple of things. I'd be interested just to learn a bit more about safeguarding ambassadors. Something about how you recruit them, how you train them. And the other area I'd just like some commenting on is regarding modern slavery. We touched on it in here, particularly in the care sector, employed in the care sector. But I wonder if you're going to be looking wider in sort of domestic servitude, that sort of areas where we have a lot of in this borough. So just a couple of areas. Some comment on.
I think certainly I think that what we've done in terms of modern slavery has been through care agencies, and we haven't looked wider than that as yet. But I think I'm very aware of the need to do that in the borough, in KC, I think, because of some of the kind of cases, that we have heard about. So I think we need to do that. But I think we have done a lot of preparatory work now with care agencies, with health professionals, making sure, again, it's about asking questions. It's about having that kind of curiosity, really, because we are concerned about the way in which that it becomes very apparent that it is taking place, has taken place. So I don't think we're there totally yet in the way that you're suggesting, Councillor, but I think that we recognise that we have more and more work, to do in that area, and we're obviously working with kind of colleagues in the council to to take that work forward. Was there something?
The ambassadors,
the ambassadors, yes.
Lots of good stuff in the report on the ambassadors.
Yeah, the ambassadors grew really from the local account group, who've always been there as a reference group for adult social care in the borough, and they did a lot of kind of outreach work, talking to different community groups and the community groups that they kind of represented, and we've been able to draw our safeguarding ambassadors from those groups.
Right.
And also just kind of generally we put the message out there that if you want to be involved, then do you kind of talk to the other kind of ambassadors and get on board with the work. So we've got kind of ambassadors from a wide range of community organisations, and they meet together regularly. They have a training programme. They've probably done as much safeguarding training as any of the staff, actually. But they're incredibly interested in all areas of the work. They're very we always talk about professional curiosity. They have curiosity that's actually from their kind of dedication to really want to do this work. And, they're always looking at what might be the new kind of areas of concern, and bring that back, to discuss in the group and bring back about what they're going to focus on. So they meet very regularly indeed. And from time to time, I meet them. And we always hear from them at the safeguarding board. So we hear about the work that they're doing. They don't want to sit through the whole meeting, but they're very happy to make a video or just come for a particular kind of issue and talk to us about it. So there's also a good rapport between the board and the safeguarding ambassadors, which is important, I think, so that, you know, on both ways we feel very connected to what they're doing.
It's excellent.
Thank you for this very interesting report. But I'm going to go back to the ambassadors question. How visible are your ambassadors? That's question one. And also, does the council have any form of set information on power of attorneys? I mean, how do we regulate safeguarding those who are turning, okay, their mental capacity is declining? Do we have any form of procedures at the council where we can ensure that our residents are being safeguarded to whom they sign their power of attorney to, so that we can support them and protect them? Because you find there are a lot of our residents that power of attorney is in the wrong hands, basically. So is there any way of us as a council addressing that situation? That's number two.
Sorry, do you want me?
No,
Sounds like
number three. And I can see that you've got an interest in the ethnicity data. What brought that on, and how are you going to ensure that is there a strategy that you've got in place to ensure that you have accurate data moving forward?
Yeah, should we start with that?
So the ambassador, how visible they are to the community?
Well, we try to make sure that, you know, we've got a lot of kind of publicity about the ambassadors to make sure that we yet again use our network to get out the message that they are there. I mean, part of the reason why we started doing the work to set up the BME network was because we wanted to make sure that the ambassadors were reflective of the very many different kind of communities across the borough. And make sure that, you know, that they have got people that they can talk to. So there's a sort of cascade effect, really, of the work that they do, that then they talk to different kind of community organisations and interpreters, and that then those messages get out into different communities. So we try to make them as visible as we can, but also to make sure that that we've got networks that they're attached to, so that they're also supported. I mean, that's also very, you know, very important as well. And so that's how the model works, really.
Okay, so that's that model. So take me back to the power of attorney. So how are we safeguarding our residents who are, you know, slowly declining in their mental capacity? I mean, is there a way of us protecting them?
Well, I mean, it's a very difficult area, as you know, it's very hard, and also if people haven't got health or social care needs, we wouldn't necessarily know what their circumstances were. So I think, again, it sort of feels like a real theme this evening. There's a real need, I think, for getting messages out there and using our kind of partners as much as we possibly can. So GPs, for example, may well be able to ask somebody the questions, or ask a kind of family kind of questions, to try to make sure that people have got those things in place. We also work with care homes, with care providers, a whole range of other kind of professional organisations, to make sure that they are on the lookout for any situation that doesn't kind of feel right, that doesn't seem to be right. But really, there is a need as well, I think, for a community messaging. It's about people putting those things in place before it gets to the point where, you know, they're unable to have, you know, they haven't got the capacity themselves, and people making sure they've got arrangements in place. And really, it's just, you know, messaging. I mean, there's not, you know, that's preventatively the best thing that we can do, really. But then again, when, you know, people are in a situation where suddenly they're in hospital, for example, and somebody notices, or actually not sure how easily this person's finding it to make decisions, of again making sure that they do what they can in terms of asking the family, of asking questions about who exactly is protecting the person's interests. So it is, I mean, it's a very difficult area, I think, but it's one that we just, you know, make sure that people are very aware of or on the lookout for.
And now I'll just jump in here. So we know, don't we, that lasting power of attorney has increased an awful lot, particularly in the last couple of years. So we've been keeping an eye on our financial abuse data, and we've been equating our financial abuse data with who is potentially doing the abusing. And it's not saying to us that, in fact, that increase is therefore saying that the lasting power of attorney is doing the abusing. So we are also being supported by our fantastic Mental Capacity Act lead, who then supports frontline and operational staff with undertaking Mental Capacity Act assessments around people's decision making around their own financial abuse. And we do have a relationship with the Office of the Public Guardian as well. So we can just keep an eye on what nationally is happening and seeing if it's actually happening at a local level. And we have not seen any indication at a local level this is happening. And we're actually at this moment in time talking to our finance team as well to see actually whether they're seeing any increases in any type of misuse of other people's funds.
Thank you.
Thank you, Chair. So I thank you for the report and all the discussion, which is all really very interesting, as it always is. I had a question, a more general question, which is, you know, you're doing these reports every year and seen a lot over the last 7 years, and you've been chair for a while now, I think. What do you think of the sort of changes from last year, and I guess the trends, like when you look at everything that's happening in the borough, where do you see the kind of risks aren't coming, where we have more needs? What are the kind of challenges that you worry about in the next year or 3 years, 5 years? Big question, I know.
Big question. It's a very good question. I think that what we have experienced is, in particular, I think in 23, 24, was the recovery from COVID and the impact that that had. And I think that what is spoken about more and what is very well documented, I think, is the impact it had on children and young people. And that has been kind of quite a focus. But our experience in adults has also been that it had a huge impact in terms of mental health, in terms of issues like domestic abuse, loneliness, people kind of living through that period that was a very kind of solitary period. That although those things, to many people, life has gone back to normal, I think a lot of people carried with them the extent that that kind of experience had upon them. So those are some of the things that I think we are concerned about. So we are during this year doing some work on mental health and looking at sort of not the mental health services where people kind of reach the threshold that they would be a service user of a mental health service, but those people who are experiencing much lower level kind of depression and isolation, loneliness, those sorts of kind of factors. So we're starting to do quite a lot of work about what can we do about that and try to meet those needs. And I think that COVID also had an impact, I think, on staffing across the care sector, and we need to kind of remain aware really of the need to kind of recruit and retain staff, and to make sure that there's that sort of kind of continuity in terms of kind of services for residents. And I think there are very good services here in Kensington and Chelsea, but it is it's good for us to kind of keep an eye on those things, and we do get reports about the kind of quality of care provisions. I think that's really important. But some of the things that I think the report that have continued to be an issue for us this year, and I think ongoingly, that so many people are looked after in their own homes, or actually themselves in their own homes, perhaps for too long before they really require help. And so for me, there is a kind of increasing need that we continue to build on our kind of community work that we do to make sure that we're always getting the message about kind of safeguarding out there. And I think in this borough in particular, actually, there's a lot of older people who are living on their own, who don't have kind of family carers, and will require kind of care support services, and making sure that we recognise that about the local communities here. I think somebody asked me earlier, actually, which we didn't kind of answer directly, about why we focused on SS2 data. And I think, Councillor, that I didn't answer that bit directly, and I think that was because that we recognise that safeguarding is a difficult concept. It's a difficult concept for people to really understand and relate to, the actual kind of name itself. But it's particularly difficult, I think, in a borough like this, where there are so many different communities, and communities need to actually grow their awareness and their kind of understanding of safeguarding and what is of concern to them. And that, for me, is really, really important in terms of work going forward, because I think it's different for different resident groups across the borough about what makes them feel unsafe, and what constitutes harm, and what constitutes neglect, and how people kind of respond to those issues. So actually making sure that we've got that kind of breadth in terms of the work that we do across all of those communities, I think is a kind of key concern going forward.
Thank you.
Thank you, that was really interesting. I've just got a couple of questions. One of them was just relating to Kwame, who is one of your self-neglect cases, and just sort of how we can strengthen strategies to engage individuals like him who may initially mistrust services, so ensuring that they feel empowered in the sort of safeguarding process. So how, that's one of my questions. And then just, I mean, I actually was unwell last week for Professor Manford's meeting with us, but James Gray sent a note on what he said, and I know last year's was that sort of we're very much up there in terms of nationally on our safeguarding report, and just therefore I do think it'd be really interesting if there was a sort of benchmark comparison as to how we are performing nationally around in comparison to other boroughs around the country on safeguarding. So I don't think that's in there, and it would just be interesting to see, because I know we are very much up there, or if you can speak to that.
Yes, the outcomes that I talked about earlier, where we have 98%, that's the only kind of national data that we have.
Yeah,
it's the only way. I mean, so the only other ways that we can do comparisons are really to be aware of what's going on a national kind of safeguarding scene, so that we're very engaged in that. So we pick up on issues and make sure we've got those at the forefront. But there aren't other kind of areas of data, but there are that are specifically about safeguarding. But what we can do is to look at making sure that across the partnership, that the services that are offered are as good as they possibly can be.
Mm-hmm.
So if your care services are good, and if your social work teams are good, if your health providers are providing a good service, then the chances are that you will have much better safeguarding than if not. So it's really important that we look at those kind of areas of services, and that they are kind of accountable to the kind of safeguarding board in terms of the quality of what they do, because there is a kind of comparison between that, I think, and safeguarding. But there is no other national data, unfortunately.
And then also I was just going to ask about out of borough placement safeguarding. So sort of what mechanisms are in place to ensure effective safeguarding oversight for residents to a place out of care and work.
And that's certainly something that we have looked at quite recently, actually looking at the arrangements that are in place for commissioning and then reviewing kind of quality of placement. So it is something that the board does look at. Not all of the time, but
Yeah.
we do a kind of a roadshow of looking at different kind of service areas. But being we have had lessons that that have been learned nationally from some of the kind of placements that have been out of London that have constituted then a real kind of safeguarding risk. So it's really important actually that we work with health colleagues on that, as well as social care, to make sure that there's regular kind of reviewing and quality assurance in not just the care homes here or in kind of care provision here, but where people are placed.
Any questions?
Oh, thank you, Chair. Just one last question. I just wanted to know, do you have any form of connection with housing associations? Considering you've got so many in the borough.
Yes, we do. In terms of the holding work, that's
Okay,
absolutely,
so
yeah.
just
Yeah.
holding for the housing association.
Well, it's not. No, it's a range of other kind of safeguarding concerns. I mean, hoarding tends to be one of the key areas.
Okay.
In relation to safeguarding, but there are other things, and understanding kind of the Mental Capacity Act and how that works and how to kind of make sure that people are protected as best that we can, whilst also maintaining their capacity for as long as possible. So those but other things that housing associations pick up on are the kind of general safeguarding messages that that we've been talking about this evening, and so they have very much kind of come on board, and that was one of the pieces of work that we did in the year. We really wanted to get in touch with them, and we're having a good response from them, aren't we?
We are. They also, their members are community engagement group. When I say they, over the years we've had organisations like Safeguarding Leave for Peabody, who used to chair our community group, and then Notting Hill Genesis, also they've been key charers. So, but what we've done now is we've actually got a much wider range through the hoarding and self-neglect. And then they'll begin, so we signpost them to our website, and the website's just a wealth of information. And we have an open door policy. We just say, give me a call or give my service manager a call, and we can pick up on situations and issues and indeed safeguardings when they arise.
Okay, so that's to do with holding. What about violence or antisocial behaviour? You tend to find that a lot of residents, they will go to their housing association instead of the council if they're housed by the housing association. And I was just wondering how can we support them in that way as safeguarding ambassadors from a holistic point of view, because there are a lot of residents since Grenfell, now COVID, recovery, a lot of local residents' health mentally are declined. Residents are not getting along. Constant argument, fights, broken windows, and some of them are feeling really afraid. So I was just wondering, how can you come in and the council to support these residents?
The most important thing that we can do, because obviously as a partnership we're not working kind of directly with those residents, but is to make sure that those housing associations know how to make a referral, know how to make a safeguarding referral, and that they do it appropriately. Because actually we're very much aware of the growing kind of fear about hate crime and people feeling very frightened, sometimes in the situation where they're living, and making sure that that housing associations do respond to those things. Because what can start as an argument between tenants can end up being something kind of much more. So the most important thing we can do, I think, is to make sure that these are the things that you should refer, and this is how you do it, and these are the kind of these are the details, and then making sure that all of those kind of housing associations get a response, so they know what's happening, they know what action has been taken.
So we deliver training to all housing associations who are known to both boroughs, and there's obviously quite a lot of crossover. And we work closely with the coordinator for registered social landlords. So I and my team quite regularly go in and talk about safeguarding and talk about referral pathways. And then with community safety team as well, we can also discuss and look at antisocial behaviour and coordinated policing as well. So we do work alongside them, and again, they can make referrals in, and we can actually support them case by case.
Thank you.
Just very quickly, on the question I had about Kwame,
Oh, yes.
and just understanding someone who maybe doesn't necessarily trust services, and we want to be coming forward in terms of self-neglect and sort of how we can kind of strengthen strategies and help those who might, I guess, probably preventative work, but what we're doing.
So Kwame is a gentleman, it's just from my memory serving me. He's on a methadone script, he's got substance misuse issues, and he's got ulcers and a lot of health issues, and that's right. So that was a health related case, but of course our substance misuse team is involved in cases like that. So we work very closely with public health to get public health messaging out to the substance misuse services, and that they're commissioned by ourselves, but they're also commissioned with health as well. And because the board's a partnership, it has an awful lot of authority to be able to work with, and we're saying quite a lot, to get key messages out through the board. So it might well be that one of our agenda items is looking at vulnerable people with substance misuse problems, and does look at engagement issues. So we do spend quite a bit of time on supporting each other with how we might engage with people who wouldn't choose to engage with us. So that's quite an interesting case, because they're actually one of the most notoriously difficult clients to try and engage with. But in fact, that was a good news story in the end, because the partnership worked together.
Yeah. Okay.
And it's really about making sure that we're saying to kind of health professionals, don't just treat the physical symptom. You know, if it's an ulcer or whatever it is, but try and kind of let's think about the whole person, and why somebody's got some of the kind of symptoms that they've got, to make sure that we then have the kind of right kind of conversations to try to engage people. So that's it's a constant theme for such.
Okay.
Really
Yes,
quickly,
of course.
just that you mentioned briefly the faith groups, and I think that is a really important, just looking at some of the subjects we're talking about here in terms of hoarding, in terms of slavery, modern slavery, and just really the importance of getting out there, notwithstanding what happened last week, to get out there on the safeguarding messaging to churches, and where often they have a slightly different relationship with people than authorities or statutory agencies.
Absolutely brilliant.
Thank you all so much. That was a really interesting presentation. Fantastic report.
Thank you very much. Thank you very much indeed.
Moving on to agenda item 5, home care mobilisation. This report provides an update on the place-based home care model and outlines the home care tender timescale with a high-level overview of the mobilisation plan. Attending, we had Gareth Wall and
Thank you, Chair, and thank you, Committee. Yeah, so we're presenting you here today the home care transformation, which is currently out to tender. Which decision will be taken early next year on the transformation program that we've proposed. So the point of this is just to get the committee's views on whether you think we have hit the nail on the head. There's a couple of things that we've done differently. I think everybody's seeing, so that's kind of splitting things up into neighbourhoods, trying to make it slightly bit better in terms of delivering the place-based service. Got digital work streams, things like that. And we've got some kind of case studies at the back as well, and what we can do as well. What we do, of course, as well, which you may not realise, is that we will only commission services that have a CQC rating good or outstanding. And that kind of puts us kind of above beyond perhaps some other areas as well. So, but this just as a really top line paper, just get your views on how we provide the service as it is and what is going for.
Gareth, I don't know if you want to add anything.
Only very briefly, that this is a really big ticket item for us in our social care commissioning. as a council, we spend about £10 million a year on home care, so getting this right is really important, not only the number of people that use the service, but the amount that the taxpayer spends on it. Just a couple of things to add on that introduction of things that we've talked about in this paper. One is the demonstration of our commitment to co-production. We've talked here previously about our co-production strategy, and in here we've got an example where people who use the service helped us design the evaluation questions for the procurement activity. So while it might have been a bit complicated to get people involved in that actual evaluation, because we've got hundreds of applications so far, the design of what we're testing those bids against has been informed quite specifically, as you can see in Appendix 7, by some questions written by service users with us. And then there's also some detail in here about the mobilisation plan itself, which, given this is a framework with some different elements to it, has a degree of complexity and length. But that's because we want to make sure that we're making any changes in people's care as safely as possible and giving them the choice that's available to them under the Care Act.
Thank you. And thank you so much for this report. I think it's clear that the plan is to move forward to a sort of neighbourhood-based model that focuses on localised outcome care and aims to improve the working conditions for care workers. The only thing I'd say from it is it wasn't necessarily totally clear what the sort of major transformative aspects were, sort of all points throughout it, but I'm sure the committee might have questions on that. And I know this is just a kind of framework, so this might just be bits that will come along as we kind of go through. But the kind of two questions I wanted to start with to understand about sort of mobilising transition was firstly, how can we ensure minimal disruption to sort of service users during the phased mobilisation process, especially vulnerable individuals who are reliant on consistent care? And also, just adding to this, how will we maintain continuity of care sort of for service users who have strong preference for the specific care workers? Two things that I achieve.
Yeah, sure. So the key bit of the mobilisation for people in that situation is after the initial contract award. So once the contracts are awarded, all new cases where people are discharged from hospital or come through social care routes will go to the new contracted providers. Key thing about this safe transfer is, and giving people choice, is for people who are existing customers on our books, if you like, and making sure that even though we're making a change in contract, we continue to meet our Care Act responsibilities by ensuring that people are offered a choice in the type of care that they receive. As a result of awarding these contracts, we will have what we're calling a patch provider for each of the 4 designated geographical areas in Kensington and Chelsea, which you can see in the map on the paper. And we will speak to each of the individuals in receipt of their care and write to them and say, your current contracted provider is changing with us, but you have a right, as anybody does, to ask us to arrange care with any provider. What people, linked to your question, what people tend to say for that sort of thing is, I still want to work with Joe. If you've got a comes around every day, and so what we have to kind of work through with them, which is why this can take a bit of time, is the question of, is Joe going to cheaply transfer from one care agency to the new one? And if so, usually what happens, and we work with the individual on this basis, we might move them from X care agency to the other care agency. It won't really make a lot of difference to the individual. It means that they're getting the same care worker, maybe wearing a different hat on, and they're coming on today. But some people might really be wedded to working with that agency. They've had a lot of good experiences with them, and so that's possible too. One of the things that we have set up in the framework is we're hoping, part of the transformation was hoping to drive as much of the activity as possible through these contracted patch providers, because that gives us much more ability to help develop the workforce, to focus on quality. But we also have a separate lot for spot provided arrangements. So if somebody wants to continue working with another agency, we'll have a list of organisations who you can spot purchase from in a compliant contractual way. That means that continuity is available to them. But the key thing why that bit of mobilisation plan we've written down as taking potentially 14 months is there's kind of quite a long tail. So the numbers get low quite quickly, but of working through those individual preferences arrangements with people and understanding where different members of staff have got.
Okay, that's very reassuring.
Thank you, Chair. Thank you, Gav. So we've talked a lot about, well, I guess my home care, but the whole home care, and it's come up in quite a few of our council meetings, and there have been questions about it. And I guess what was sort of slightly missing for me in this paper, and maybe you can talk about it, is what are we going to do to try and improve that situation that we've seen with my home care? And should we be sort of identifying what maybe didn't work so well last time round? And I know this is so difficult for all the reasons that we've endlessly talked about, and the caregivers are very difficult to retain, and they don't get paid very much, and it's all quite transient, and there's not enough of them, and it's really just it's a very difficult marketplace, the whole thing. But I guess for me, this paper just glosses over some of those real difficulties that we might not be able to fix, and we might have to some extent live with. And how are we going to manage those? And I think we just need to be a bit real about what they are, and because it just looks to me a bit like we're going to, we spend all this money and we're going to fix everything, and we're not. I just don't think these things are going to go away.
I think that's a good point. I think perhaps reflection, going forward, we'll kind of do that as well, because what the report tried to do is just an overall vision, but what you actually said is absolutely true. Hit the nail on the head. There is challenges with recruitment, there is challenges with retaining that recruitment, there is challenges with getting people to the right places and the right type of people as well that can get back in cases as well. The wages too. I mean, all that is very, very, very valid. That's not just an RPKC issue, but that is an issue everywhere. But I think what you're trying to say is the way we frame the report, it sounds a bit like it's all funded up limits, so we go through this effectively, which is a reasonable criticism on that.
I don't think it's a criticism, but I think everybody needs to be real about what the situation is.
Yeah.
And I think if you read this kind of cold, you think, oh, that's great.
No, it's a good point.
And it's really not going to be perfect. In fact, it's probably going to get more difficult than less.
Yeah, I mean, obviously the implication is, that is true. I think everyone agrees at this stage, hence why we did it the way we did, was to give it a really top line view of how we're going to make it better, rather than it's going to be like the best thing in the universe. But all those points about it. Gareth, did you want to come back on a couple of points about especially recruiting staff and the retaining of staff as well?
Yeah, just a bit. So on I suppose because we're in the middle of the tender, I'm trying not to talk about my home care specifically.
Yeah,
sorry.
But in principle, with one of the criteria that's in the first stage of this two-stage procurement process is an absolute red line of any bidders needing to be at least good based on CQC. So to be one of the geographical patch providers, they have to pass that hurdle at the first stage in order to get to actually submitting a full tender. But you're absolutely right. We could get through the full contract award process, have our 4 geographical patch providers rated good or outstanding, and CQC could come in a few weeks after we've awarded the contract and actually find through their lens something that can happen on the day. We know that can happen, and so our response to that, working actually with Louise's team in quality assurance and with our colleagues in social care, would be to follow, in any instance, it would be to follow the same process as we have followed with my home care, which is the London-wide providing concerns process that involves safeguarding, quality assurance and commissioning to fully understand what it is that's changed in terms of CQC perception and help that organisation to improve within a kind of, but I think something that we do differently perhaps from the stage we're at now in that is within a given time frame. So we have contract measures now, and we will have in future. So actually, if the improvement doesn't come within a certain time frame, then we'd stop and change. We haven't done that today with this one because we know that this procurement is coming up. And actually, even though the rating hasn't changed to date, we've seen in detail the journey that particular agency has gone through that's given us reassurance to believe that that's all right.
I'm sure that's
The other thing, just in terms of the points around recruitment and retention, and some of the things that are different about this contract that we think might help to safeguard us from that situation in particular are this quite close modelling we've done on the relevance of the geographical patches that organisations will be working on. It gives a much stronger chance for the awarded agencies to work on smaller footing, to be able to attract people to work for them because they will have further distance to travel between different visits. That there's strong encouragement in the specification for them to continue offering guaranteed hours contracts to people, as well as making use of flexible 0 hours contracts when that's people's preference. And so there's a number of things in there that are designed to make working for one of these agencies more attractive, and in addition to, at a minimum, paying the London minimum wage as an hourly rate. So there are so one other thing that we've done with the agencies is to agree that they would be paid on what we call adjusted plan arrangements. So at the moment, what some councils do is pay just on hours delivered. So if somebody, if there's a late cancellation, for example, that we're not notified about, we might still end up paying for that visit. Or if a care package hasn't been suspended when someone's been in hospital because we don't know about that, we might still end up paying for that. There's been an adjustment to the way that some of that will work, which will mean that the agency has a kind of degree of tolerance that when things change in short notice, people will still get paid. So there are things like that that we've put into the design of this through work with the market, through work with our social work staff and with service users, that we think can all move towards strengthening the position of those patch contracted agencies. And we've also helped them by separating out a spot provision for where there isn't capacity, and that will give us up to 10 extra agencies on contract, and a specialist provision. And then this is new too for what we call complex by exception. But that's where sometimes agencies might struggle to be able to provide capacity for 4 visits a day that are double-handed visits, or where someone's got particularly complex behaviours or a particularly complex medical case that needs some specialisms that those patch agencies wouldn't necessarily be able to do. To put that in a separate model so we can really build up the skills of staff and those agencies will be able to deliver that. There are kind of a range of changes in here that individually look kind of quite kind of small shifts here and there, but actually it's all kind of nudging and moving towards a more roundly supported local market is what we're aiming at.
I mean, I know this is an overview, but I think it's really helpful to include some of those things, for people looking at it beyond the committee. I think there is going to be a lot of attention on these new contracts, especially what's in the past.
I was going to say, without mentioning the agency that we're talking about, can you still apply go through the tender process if you're at a stage where your CQC rating isn't up to the standard you're talking about? Or do they have CQC inspection before you make that decision, or how does that work?
So agencies that want to apply for this and know that this is our criteria can request that CQC comes sooner, so that will have a chance to meet that criteria before our tender closes. But we just have to be very clear with the market that that's our criteria. We don't.
That's good to know.
And you've got enough of those to make it a sensible process.
We've got a really good number so far, yeah. Really healthy competition.
Oh, good.
Yeah, I had a question about spot providers. What is the intended use and how they're going to work with the general system?
So at present, we've got a smaller number of geographical patches, and the aim has been in those contracts for those contracted agencies to accept 100% of all the referrals that are made to them, whether that's people coming from hospital or people referred from the community. And the reality is that because those patches are quite big, they're not often able to do that. And often we're kind of bordering around 40% of our home care provisions is spot provision, not through these contracted patch agencies.
Okay.
So effectively, when a new home care package needs to be set up, our brokerage call first the contracted agency, can you take this package? And if they say, sorry, no, we just don't have enough staff at the moment, then we've got a list of other organisations that we can go to. We put an individual contract arrangement in place for that.
Okay.
The difference here will be, we're trying to create a situation where the contracted patch providers will have more capacity to be able to accept 100% referrals, but also that we have a compliant way of working with, I say compliant, I mean that a kind of a more regularised way of working with 10 spot providers who don't pick up the phone to you first, because that goes to the patch providers, but who we know we work with regularly. So of that 40% that's spot provided at the moment, in total, we probably work with about 20 different agencies, but really there's about 5 or 6 that we know we can go to regularly as backup capacity.
Okay.
Part of what we're doing here is just putting that in a regularised position, so that we also then have a more regular contract management, quality assurance, safeguarding relationship.
Okay.
Just to pick up on some points that Anne was making, but para 1.3 of the summary. I mean, I guess the issue for what I find as a counsellor dealing with surgeries and people coming is actually what the end user experience is. And I guess this is a high-level report. I'm confident that the process stuff is happening. What I would need to feel a bit more confident about is that will translate down to the end user. And the stuff in para 1.3 is all really good stuff, but it's just going to make it understandably harder to recruit, put more pressure on the suppliers. So there's no real answer now, but just actually, in addition to focusing on the process to tender, it'd be really interesting to know at some stage more about what the end user is going to experience and how that's going to be different.
Thank you for that. And as this is something we regularly come back to the committee to talk about, I think we could endeavour to do that once these are in place. There is one point just in the appendix to this report. I won't scroll through it now, but there's a list of the key performance indicators that we're associated with the contract. And at the end of that list, there are some that are outcomes focused.
Yes.
And I think that might be something that we can come back and reflect on when we've got some of those.
And how presumably there's going to be strong monitoring as well. CQC, there's strong monitoring by us, absolutely, on the contract, and just some more around that stuff. And it's in here, I know, but it gets lost in the process.
Yeah, well, I'd be really happy to come and talk to you about, but as those, because they're quarterly contract performance arrangements that will happen along with an annual review of the agencies, and perhaps when we're a few quarters in, we can report to you what's those products.
Thank you, Chair. Thank you for this report. It's just an observation. Actually, one question. Who selects the patch to where these organisations work? Who selects these patch?
So between, largely it's our commissioning team, working with safeguarding service users and the market, using modelling based on the activity data that we have at the moment. So what we did was basically map out the hot spots on the map where most of the packages of home care are, and try to draw a line around those in equal numbers, so that we could do two. Sorry, so let's explain this clearly. So we could do two things. One was try to make them as kind of geographically sensible as possible, so that for an agency trying to plot a rota, they could minimise the travel time that somebody has between different visits. But also so that the volumes of activity with each of those packages were attractive enough so that we could get really healthy competition.
Yeah, I understand.
So without seeing the
I understand, but that makes sense. But when you look at it, north and the south, who's in charge of the north and who's in charge of the south? The quality of care and the provisions. You see my point? I don't really want to go too much into it because Health Vision, they're based in the north of the borough, but then they deal with the south.
Yeah, so in this one on
is
page,
in the north. So that's why I was just thinking, who was the one that's selling their patch for them? That's it.
That's just the modelling bit. So in the new one, we'll have Oxford Gardens at one top and then and Love Progressive. We'll have 2 patches in the north this time.
Oh,
We
good.
will expect them to be based there.
Oh, vision. Yeah. Thank you.
You sound excited.
Thanks, Georgia. I've just got a couple more questions. How will we continue to involve service users in this sort of evaluation and ongoing improvement of that sort of post implementation? So sort of what feedback mechanisms will that sort of be a big part of it?
We'll definitely still continue working with the local account group as and the safeguarding ambassadors as a way for us to have them as representatives, I suppose, of service users to inform some of the work. An ambition that we've set ourselves across a lot of different contract areas from the co-production strategy is to kind of, well, I suppose when we can catch our breath on this, is find ways to design the potential for service users to be involved in contract management in a way that's kind of proportionate and might be of interest to people. That might be a kind of a balance between quality assurance roles that Louise's team lead on and contract management that my team lead on. And often they're kind of both talking to those agencies about their work. It probably wouldn't be through a regular quarterly contract management meeting because they're quite a formal setting. But we would have an ambition to find a way to make that possible. But we do things like have regular provider forums where there's a bit more of a kind of an open exchange rather than a kind of one-to-one contract management arrangement about what are the issues. And sometimes that might be where providers will come and talk to us and say, well, we've all got issues with the way that invoicing and purchase orders go. So can we talk to you and your finance team? And we might do one of those. But we might do another one that is very specifically about talking to service users along with that. So there's structures we can use to do that. But our co-production strategy absolutely commits us to involve service users.
Any other questions? Thank you. The only thing I was going to say was, what in terms of the committee, what are we working with you on? So when do we see sort of your next stage or hear?
The next stage we're just about to complete the first stage of procurement, so that the first hurdle, which includes the sea listing. Then the shortlist of providers are invited to bid. We should get before Christmas to a position where, with that all of that's completed, we then review and evaluate the bids into the new year. And so we will come to, well, I mean, there's a formal kind of decision and notification process around that, but we'll come to you and see if we've got an outcome.
Great. When do we know? Like,
Be before the end of the financial year, so I've got to be quickly.
Very much. Okay, that's very good too. Thank you both so much.
Thank you, Liam.
Thank you. Moving on to agenda item 6, which is the annual complaints report. The annual complaints report provides an overview of complaints and investigations into adult social care between April 2023 and March 2024. Attending, we have Councillor Josh Rendell, Mr. Savas Prison, and Louise Butler.
Thank you, Chair. Yes, so as you know, every committee will look at their respective portfolios, report, and a bigger report will go to the OSC as well, at the council as a whole. But we'd like to present tonight our ones for adult social care. So we've got Louise and Seth. Yeah, I joined them today, and I must say I've been really impressed by the Louise's work and the whole team to get our complaints. I think probably the best in the whole council. And obviously, we are often dealing with very vulnerable people with very high needs, people who are kind of right at the face of council services, and how we kind of do. And I think how the team have gone about it, especially from not just inquiries or complaints from service users, but also from members as well. We're really out there. And I think we respond to all complaints within 10 days by about 74%, I think it is, which is really, really impressive. And overall 20 days. Obviously, we try to keep that as low as possible. Obviously, there are 1 or 2 complaints that have gone to the ombudsman, etc. But you know, we've stated in here how that kind of has come about, the reasons, the lessons learned from that as well. But in terms of how we do it, the timelines we do it, and ideally communication, which is kind of some of what the complaints are about as well. I think we've done an exceptional job on that, and I think the data and the facts speak for themselves on that front as well. But as I said, Louise and Tel will be able to take kind of more detailed questions on that. But in terms of how team update me, we get frequent briefings on this myself, so we can talk through each individual case, lessons to learn from each case as well. So in terms of direct accountability between officers and lead member, I think very, very good, and obviously myself in front of you now as well, for that particular mechanism as well. I think it's really, really positive. But again, happy to take questions on it. But as I said, I think it's just really impressive what everyone's done so far.
Anyone else?
It's just to say, so obviously a lot of work's happened over the course of the last year or so. Lots of improvement in performance in terms of the way we go about approaching our complaints, encouraging complaints or working with our residents, as well as the training that goes to the workforce, so they have that professional curiosity, as well as managers when they receive the complaints and how they respond to make sure we keep within the timescales.
Thank you. Louise, I don't know if not, we can start questions if you want to add anything.
The only thing I was going to add, because I wasn't really going to go through the report at all, I was just going to really say that, as they're saying, an awful lot of work's taken place in last year, and this is actually last year's report. So we are incredibly focused on having a high-functioning complaints team. We've reviewed where the team sits. It now has a very clear remit within a safeguarding, quality assurance and complaints team. We have a joined-up learning approach, which we can talk a little bit more about. And in fact, we have an excellent monthly performance meeting where we really look at our key performance indicators. And as we know, as from about this time last year, we were looking at 90%. And we did have to play catch up, and we explained that last year in last year's report. But in fact, remember also that we have a one-stage complaints procedure, and the majority of other departments, well, in fact, all departments have two. So in fact, the total for 20 days was actually say 87%. So we have played catch up, but very, very happy to discuss it in a bit more detail with any questions.
Thank you very much. And I know how much hard work's gone into this and improvement over the last year. So thank you very much. Portia, do you want to start?
No question from me.
No, I was very impressed. I think the obvious improvement is the response time that came up. So well done on that. I suppose my question is very much like, now that you have played catch up and then you have significantly improved the response times, where do you think the next area where you're going to focus is going to be? Because obviously you still need to dedicate qualitative amount of time to each case. So there's only so much contraction on the time response you can reach after a certain point. So what's the other area do you think you can work on?
Well, so we do have a program of learn. So from the themes that we get from the complaints and the key items that come consistently, there is a framework we have now around the learning. So we feed back to the teams around actually, these are things that are coming through the community, and how do we address it to make sure those things don't happen in the future? That improves the experience of the resident. Will you take up to some of your framework?
Yes, absolutely. So the framework includes training up frontline engagement officers with how they communicate with that with the person who's complained, and carries them through the journey of that complaint. And even though they were doing that before, we're actually using a very strong strength-based approach now. So they're really holding that complainant. So that's one thing that we're doing differently. The other thing is we're joining up what we're learning from my quality assurance team, what we're learning from safeguarding, and they're all quite similar. So they might have different varying degrees of severity, but they're all quite similar. So we now have quarterly meetings with principal social worker to make sure that all the learning goes down into the trainings. And we also then have immediate learning, which goes back out to the teams and the people involved. So we do as much as we can face to face, because I think that's a better way of learning than just doing it over Teams. And we make sure that there is confidence building within the teams to be able to understand what good looks like. So the other thing that we're doing is we are then speaking to the complainants, but in a more broad term about how was it for you. Now, we've got to be quite careful there that we don't actually open up the complaint again, but we're certainly having to have some type of evaluation feedback loop, which we didn't have for. So it's quite a solid learning programme, and we're just using what we've already got, the systems we've already got in place to make sure we triangulate out the learning into the training, and then we really use this very solid motivational way of just ensuring that the complainant is actually held through the process, because the majority of the complaints, interestingly enough, are not upheld. So you need to support that person to explain actually why it is that we feel that the service has done it a specific way because of X, Y, and Z. So we have to be very sensitive and compassionate in how we manage this type of situation.
Thank you. I read this paper and I just kind of struggled a little bit to sort of, I don't know, kind of touch and feel what it's really sort of about. I mean, 91 complaints really doesn't feel like very many. Particularly because I know that some people just love complaining, so I'm sure you get some of those. Some of the complaints I'm sure are, things that we can learn from. Can you just give us some examples of what these complaints are? I know there are some here, but these don't feel like very serious complaints. I mean, what's like the worst complaints that you've had this year? And another question that I had is, again, just so we can feel a little bit what this report's about. When I was talking to David Bello and I said, oh, it feels like the bar's very high to have the complaints upheld. And he said, no, I don't think it is very high. So can you just talk a little bit about that, how high the bar really is? And do we catch all the people that really are complaining because there's something wrong, and we sift out the ones who just complain because they complain? Do you know what I mean? I'm not being mean to them, but
no, not at all. So we just let's just quickly look at home care. So I have a quality assurance team who actually go talk to home care about the complaints that are being raised directly with home care. So they're filtering those and looking at those and actually saying, will you please make sure that your service user can also complain to us? So they do complain to us. I suppose that's when the bar gets pushed up a little bit. So I mean, if it's a really serious complaint, clearly it goes to the ombudsman. And in fact, there was only 2 ombudsman cases in Kensington and Chelsea for the whole of last year.
So what sort of things I know you can't talk about specific cases, but what kinds of things?
Delays. There was a delays in terms of so there would be a joint complaint with housing, and there'd be delays in terms of hospital discharge and putting in reablement or something into somebody's house, and then there'd be a delay with the equipment coming through, and the communication would be quite poor, and the service user would be, this is where it goes back to communication, would be hearing something that the social worker said they didn't say, but the service user said they did say, and it'd be about time frames and feeling let down. So I think we're doing an awful lot of work in what we communicate, how you can, what the difference between listening to somebody and hearing somebody. So there has to be quite a lot of reflecting back, and I think this is a lot of work we're doing within our strength-based programme, which is why we've got now this learning loop, so we can actually support teams to actually, rather than just put down communication. And I do hear what you're saying about it being quite bland in places, just putting a little bit more into that to understand what that actually means. But I think the quality of the service. And interesting enough, listening to Gareth Wall earlier on, only 9% of our complaints came through from home care professions.
Yes, I saw that.
Whereas last year it was 18%. So that's telling us that something is actually working. But the majority of the complaints come through care and assessment, which would be the right place for there to be, because that's where the majority of the work is. So we do analyse the data within the complaints to make sure that we feel that the trends that we're seeing and hearing at a strategic level are sort of coming down at a local level.
In terms of some of the big complex ones, I think some of the challenges sometimes with good partners. We've heard previously about housing, and sometimes with health. I think of one where the health made a decision that really wasn't person-centered, really wasn't considerate. And because obviously there's that relationship with social care, the complaint came through to us. We had to kind of pass part of it over to health, who have their own complaints process and their own statutory timeframes. So they kind of had a position they maintained, and that was accepted. So even though the complaint came through social care, it was a decision that social care could not make because it was a NHS-led decision.
Right.
So sometimes that's where it gets complicated, and it does feel like maybe the bar's high, but it is that sometimes vehicle parks can be really complex. And so obviously the user experience is, they just need an answer, but it may not be a social care issue.
No, I can see. Okay, that's really helpful. Thank you.
I just have 2 questions. Firstly, just in terms of external partners and what mechanisms are in place to hold them accountable for timely complaint resolutions. I know that's something you mentioned in the report. And then in terms of key contributors to delays, occupational therapy services and care assessments, what's being done to address these sort of delays if they are specific to particular areas?
So a lot of it is around training and making staff aware. It's just a 2-pronged approach. There is things around responding to residents, hearing what they have to say and us understanding that. But then also there's things our teams need to learn. We need to make sure they develop their understanding and make sure their teams are more responsive. So things like if there's delay in a home visit, one of the things we want to prioritize is making sure people are acknowledged. So when people respond to us or contact us, we acknowledge the contact and ensure that there's a quick and swift response to them. And then making sure people have a time booked in to their visit. Beforehand, maybe that was not as timely, maybe it was not as, clear communication. So that's some of the things that we look at within our services and ensure that the managers and heads of service understand those issues and try to be a bit more proactive in that. That's because you can imagine that's an ongoing piece of work. That's not something that we can say has been resolved.
Yeah.
But it's something that we want to definitely enforce in terms of the culture learning. So it's more of a learning culture. People understand these challenges. And one of the things, as Louise mentioned, we have a dashboard and we have a monthly performance meeting. So the heads of service attend that. We show them the different issues that are coming up on a monthly basis. So they're also understanding these issues and trying to, translate that down to their teams.
Yeah. And just on the kind of external partners and what, if that's how we can deal with that.
Yeah. So do you want to?
Well, in terms of external partners, I work closely, or my team work closely with commissioning and with quality assurance. So we make sure that not only within the contract monitoring complaints is on the agenda, but also the quality assurance team go out and visit home care providers. And this is where they discuss about complaints. So we do work really closely. It's within their contract monitoring anyway, and it's within their contracts.
Yeah.
So we do triangulate. And incidentally, we also talk to CQC. So we have regular meetings with CQC, and what we're trying to do is to triangulate information sharing across the patch, including other meetings where up-to-date information is just coming in all the time at quite a low level. So we can begin to pick up themes and trying to catch things before they become too big, particularly when you're looking at a large-scale provider concern or something.
Thank you.
Just one question. No, it's just a general. You said one of the reasons why you get complaints because of lack of communication. So I was just wondering if you are aware of the amount of different languages in the borough and if you've got enough staff to cover that, because oftentimes our residents, they get frustrated when, they're talking, the other person don't understand what they're saying, or they hear it wrong. Even myself, I hear T instead of I sometimes, so it's about having that connection for that resident. Does she speak, South African? Does she speak Arabic? Does she, so that will reduce the complaint. So I think that's something that we could look into as well in terms of
so we've done a bit
language
of work on,
barriers.
so we've done a little bit of work on ethnicity data and just having a look at ethnicity. I'm not saying language yet, but we do understand, and we've got stats here to show us the fact that I think you're absolutely right. We need to pay more attention to different languages and using some of the work that we've done in the other agendas, such as safeguarding. We can actually then triangulate that across into complaints. We do have a reasonably good interpreter service, which we use as well. So language should never be seen as a barrier, but it is seen as a barrier. And it's something that we need to pay a bit more attention to. But it's interesting enough, it's not really come up too much within the complaints agenda. It's come up within safeguarding a lot.
Okay, the reason why I say that is because if I'm the officer that's taking all this information, the interpreter might not be with me at that time. So the information I'm giving the interpreter could be something different. So that's where there could be a miscommunication, but I'm not saying that you're not doing it right. I'm just saying that's another angle that you can look at in order to get effective communication.
Yeah, but as definitely, Councillor, but as Louise said, because we commission a interpreter service, and a lot of our staff as well come from various parts of the community, what we try to make sure is that at the point of contact, we acknowledge the preferred language, and that we make sure we make arrangements so that when the person's having the assessment or they're talking about their personal, matters, you're somebody that can obviously give us the correct interpretation of things. But then people always get a copy of those assessments afterwards in the languages that are suitable to them, so they can verify that what we've taken as information is correct. So we do make sure we commission that kind of arrangement.
Brilliant, thank you.
Thank you. Thank you. Anyone else? Thank you very much for covering that. And I'm very, also Steph, sorry for calling your name. Reading off the stage. Thank you. Moving on to agenda item 7, work project, our work program report. This report sets out benefits of activities, work, and identifying priorities for the institutes of this. Is the select committee happy to take the report? What am I doing?
Yes.
And read, including the responses, the recommendations.
Are we going to vote through on it?
Yes, that's okay.
Only if you have any questions about the response.
Yeah, does anyone have any questions? That's
If not, the only things to update you about.
Okay.
There wasn't time to put it in the paper, but from today, the NHS have said that their consultation about palliative care is going live. So that's going to run until the 24th of February.
Great. And do you have the link?
Yeah, I'm going to send it to you all.
Brilliant.
Straight from this meeting. I only actually got it myself at 1 o'clock today.
So it ends on the 24th of November.
February.
So it's starting today. It's going on the 24th of February. So obviously this is something which is, I know the committee is very interested to this issue. You've looked at it twice before. So maybe something that you may want to consider making a response to as part of the whole consultation process. So I'll send over all the documentation and just leave it there for
So we can make a response as a committee.
Yeah, absolutely. I shouldn't see why not. I mean, obviously we know that North West London Justice has looked at part of it, but obviously because it's done a lot of work as well, I think it's important to you as members, it's your residents.
Yeah, thank you so much, James. I think that's real helpful. 24th of February.
Yeah.
I think that concludes this meeting of the committee. Thank you everyone for your time and attending.
Thank you, Chair. Thank you, James. Thank you. Oh, a point of correction.
Sorry.
A point of correction. The minutes. Oh, if you want, because I thought we were writing.